I tried to make him have a urticaria before. I have another guy whose asthma is totally controlled, never used inhaler. Didn't you?
I've never seen cheese that doesn't melt.
But his IgE came back wrong. So they wouldn't, as soon as he was up, they stopped it. And then one of my partners stopped it. And I said, when is asthma? I said, well, do you have a hive? He goes, yeah. Where is it? Let me see it. I saw one hive and I reapplied and got him up here chronic idiopathic urticaria. Now it's asthma. Of course.
Not too bad.
You know better than me. They're out of town. I have no clue.
Wait, in line for like a half an hour.
So I wrote a nice paper trail. Fail singular.
Don't get it beat up.
So
Can you put mine on?
but that was,
Like back.
yeah, but it's just dumb that you But with all these drugs being so expensive, I mean, it's really not
That's what I
like,
want to try to
I
get.
mean, it's not like I don't understand it. You know, but
No, I said like, but
yours is the first. And the one that's used the most. So, I mean,
Yes.
when you look at all the different pieces, but it doesn't matter because logic has nothing to do with these decisions.
You know, when I got my MPH, my final paper was
Yeah, I'm doing two cities this way.
tested evidence-based medicine on formulators.
It's probably zero.
Exactly, it was all price.
It's all zero.
That was my conclusion. Evidence-based medicine has nothing to do with it, that's everything.
What have you been doing in
Well, as I get closer to retiring, they asked me in the clinic if I wanted to be in the
your last week?
psychiatrist for secondary medicine. And you said, of course. I said, well, you know, what does that entail exactly? And they said, well, you basically keep doing exactly what you're doing. And I said, well, that's not so bad. And they said, and of course you'd be working towards your master's in medical healthcare administration. I said, that's a deal breaker.
So the
Very
learning
happy
review
with a master's in a
next
PhD.
year.
And they're like, what? I said, yeah, I'm a biomedical engineering. Does that work?
What?
And she's like,
but look at this now.
when did you
made the
tell us that? I
process
said,
that goes
that's
and
not
merge
important.
with
Well, it
the
doesn't
actual
really matter. I mean, what do you do with a bunch of more degrees?
display.
Anyway, but it was so funny, but she's thinking she's getting me talked through it, and I said, nah. Looking towards the masters, I'm out. Okay. It's a lot of work. Oh, that is, and I don't have any interest in doing that. I mean, I don't mind doing what I'm doing, but I'm not going back to school.
You can go online, you know.
Yeah, I'm not even gonna do that.
I'm just teasing, you know, that's happy ads on TV now, I swear. Yeah, I'm gonna retire and get my PhD.
But you guys would be 70 to figure out how to treat erectile dysfunction with Zola. You'd be rich.
And lose weight.
Yeah.
I don't know which it is.
And if it treated reflux, that'd even be better. That's what we need, is a drug that treats erectile dysfunction, nasal polyps, and reflux. And we'd be,
Triad, huh?
we'd be set.
I think I just named the topic.
What is it called? I don't know.
You know, we're looking for something that we're pretty sure we should. Okay? We just haven't found it.
Hey, how you doing?
You did? Congrats. It is. It's a bad thing, but it's a good thing.
Well, Sue has no idea who that picture
Like
is.
the East Coast a lot.
You don't know either.
Just
Some guy was just up on the mountain.
not a lot.
I haven't asked Steve.
A lot recent.
I'm sure it's one of his buddies from Utah from the ITS meeting we used to go to. I'm sure it's one
How
of
you been?
Steve's friends. I have no idea.
He doesn't get down to Seattle like he used to. He had to come down to the meetings that he see him once a month or so.
So he didn't come down even that often now?
Now he has to go to,
There are some
Boulder.
studies.
I think he works for now is at headquarters in Boulder.
Good.
At least he's got someplace nice to go.
We kind of found different results in overall. I know. Are you?
So this,
I'm not spending any time with my mom right now. Oh, that's fun.
How was it like the vacation?
you know what? And
Full time or?
Well, not exactly.
how about yourself? So
Why people do that?
I'm there 3 years.
Sounds like more of a consulting advisory job.
All the drugs, which is great.
Awesome.
You know,
I know they're always,
I know. start doing my sugar stuff. Last minute.
What do you do?
Well, I asked Sue if she said, we're gonna forgive Steve for being Delaney, and she says no.
Huh?
I said, so should I eat?
Oh, no, I meant for
I'll try. She goes, yes.
They always do.
I said, so socializing with Steve and Susan, no. She goes, you can go without me, you can invite whoever you want.
That's good, huh?
So maybe Nancy, like you, and Steve and Susan, and where was you have a nice time with their good sushi.
She feels like going on a 3 hours.
Well, I said, if that's my option, she goes, what? I said, if that's my option,
But then, you know, like,
what I'll be doing is exactly that. She said she didn't like that. Very much.
Yeah, we do know.
So why do you want me to retire? What was the benefit of me retiring? Get me off the payroll. Save money. So Sue goes, why are you even retiring? What do you do? I said, I'm not sure, but they'll tell me it's in my best interest to retire. She goes, okay.
You've been waiting.
So I said I would ask you when I saw you what the benefit was for me to retire. I said, I haven't.
I mean, I gave up.
Well, Bill, I was wondering the emeritus status for
I mean,
parking.
I don't know what to do.
Did you get parking there?
No, I have to do something. You have to give me the blessing.
Their policy's absent.
Oh, you, yeah. The permit, not, right, did you register?
Pushback.
That I have to be an emeritus professor.
They have,
Unless you want to do.
That was the word she used for me. So she
like
goes,
these.
That would be nice.
Right.
what does that mean? She says,
You get to park at the Husky Games free.
This is so helpful.
you have to go to a Husky Group park there.
Can see it.
I watch them on TV.
Well, you can park in that lot, and that lot is real handy to the library.
It's a lot cheaper to treat.
Yeah. Let's go ahead.
But if you have like real access.
When I see people, I still talk about that.
Drew, we still have one hours.
It's on the, I think it's
Where
just
you
the,
can,
I think it's the, your finger on there. I don't know that we have it on the house.
all right. So today is journals, and two of our scheduled speakers were too busy preparing their Halloween costumes. Mouse, isn't that green mouse?
You did, but again, somewhere in the room, I don't know.
Yeah.
Somebody put a mouse trap out there.
I know.
So, Paul kindly, when I called him, stepped in and did an article, and I very quickly just did two. And frankly, I haven't even read these articles in total because they're very complex. These are, to show you one of them here. I mean, this is the full thickness of the article with all its appendices. I'll get to it in just a second. So when Dr. Cooper was here a couple of weeks ago, we engaged in a discussion in the room here basically about relative efficacy of the new anti-eosinophil, anti-IL-5 biologics that we have. And so now there are these two competing articles about indirect comparison of the relative value of these. And since this is a pretty hot topic and sort of exciting that we have multiple new biologics, I thought I'd bring it up for discussion. And partially I'm bringing it up for discussion because they conflict with my initial bias. So I'll tell you what my initial bias was, because I want to get people in the room discussing this. That's more really my reason for bringing these two up. So I just sort of naively assumed, without reading the literature terribly well, and I'll just tell you my bias straight out, that benralizumab, Fasenra, is going to be the most potent of these molecules because its mechanism of action was different, that it was directly or indirectly, but toxic to eosinophils and would bring their levels down faster and more completely than its competitors. So that was just by bias, without any knowledge and without a lot of experience. None of us have had a lot of experience using them. And these two articles don't agree with that, and they don't agree with one another. And since there are no head-to-head comparisons, and probably never will be any head-to-head comparisons, because it's not in the best interest or interest at all of these companies, once they have a marketed product, to then engage in a head-to-head comparison where they might lose. So it'll probably just stay the way it is. So that's the premise of this. So one of these papers is entitled Matching Adjusted Indirect Comparison of Benralizumab versus Anti-IL-5 Inhibitors. And this one, to my knowledge, that's the very thick document that I showed you, is still in press, but I got a copy of it. So they performed a matching adjusted comparison of benralizumab or Fasenra versus its two competitors. And theoretically, at least according to the authors, did a very precise matching of all the parameters to say that this, although not a head-to-head comparison, was a very good matching. And came up with the fact that benralizumab and MEPO reduced exacerbations each compared to placebo 52 and 49%, so essentially equal. And they reduced exacerbations requiring hospitalization or ER visit exactly equal, 52% for each. Similarly improved FEV1, and then in comparison with resolizumab, there was not enough data matching to compare the two. So this particular indirect matching would say MEPO and benralizumab are equal in their efficacy. That didn't match my bias, but at least said that the two were equal. Then the other paper, which is already published and more of us are aware of, was the one from Phil Bussey in the Journal of Allergy Clinical Immunology. I think it was in September. I didn't put down the exact date here. Again, was anti-IL-5 treatments in patients with severe asthma by blood eosinophil thresholds, and again, an indirect comparison. So they, again, indirectly tried to match all the existing studies of these and compare the three drugs using each one having its randomized controlled trials in patients age 12 or greater with severe eosinophilic asthma. And again, measured clinically significant exacerbations, change in asthma control questionnaire, and FEV1 as the outcome of each of these studies. So they came up with the fact that all three of the treatments reduced exacerbation versus placebo in all eosinophilic subgroups. So they confirmed, obviously, the individual studies that all of these drugs work. But came up with the analysis that MEPO reduced exacerbations between 34 and 45% versus benralizumab across all the eosinophilic subgroups, and by 45% versus resolizumab. So in other words, their conclusion would be that MEPO was the most efficacious of the three treatments, not agreeing with the other analysis.
Len, what do you mean by that second statement there?
MEPO, this is the way Bill Bussey phrased it in his, but what he's saying here is that MEPO was between 34 and 45% better than benralizumab when they matched it by different eosinophilic subgroups, 150, 300, 400.
Did you, with that first study, did you get a chance, were they comparing how many of the same studies were used in both papers?
Yeah, honestly, Bill, I didn't adequately read the paper to get prepared for today.
Presumably that first paper was like this one, using...
The same, yeah, they had the same basic studies. And you may remember for when Cooper was speaking, so to be honest with you, he came as a representative both of GSK and UCLA. So he just put up the data from the Bussey study. And there was a guy sitting behind you, coincidentally, in the room who works for AstraZeneca. And they got into a discussion, and the guy in the back of the room basically said, we did better matching than you did, was essentially his analysis. When we dug into these individual papers, we matched better. And the two of them sort of agreed to disagree. And hence the outcome of these two different studies.
Looks like this one needs one of those Cochrane meta-analyses.
So I mean, the punchline of what I'm saying this morning is these two groups went into the data, came out with different different answers, that either benralizumab and mepo are equivalent, or that mepolizumab is the best of these molecules, and we really have inadequate data to really make any judgment about resolizumab. They all are better than placebo, everybody agrees with that. So I just threw these up. I don't know the answer to this. I actually have not put enough patients on these molecules yet to have a personal opinion. I told you my personal opinion before looking at these papers. And I didn't know how many people we have in the room this morning to throw their opinions in as to how many patients they've started on these drugs and what their biases are. I don't know if anybody in this community has had enough experience, but I welcome your input. Bill, do you?
Well, we have a lot of patients on each of these, but we haven't systematically analyzed, or we haven't. I don't, multiple practitioners.
Which anybody you think failed one, and you said, well, maybe we'll do better because the mechanism of action of this one is different than the other one.
I think Matt's got the best experience there, but those were kind of not the traditional patients here. They've got other things going on, like severe ABPA, and or they had vasculitis, or eosinophilic pneumonia. One, it required a different combination, but usually with adding omalizumab to it, one of the anti-eosinophil therapies. So kind of a different experience there.
I think I initially got a bad impression of mepo because its cutoff for acceptance is lower at 150. And honestly, all these drugs work better the higher the eosinophil count. So it was to the company's advantage to get a cutoff of 150 because you get more people on the drug. But on the other hand, if you put people with low eosinophil counts on, you get less of a good response. And so at least my impression was you pick people right at that cutoff, you didn't get terribly efficacious results. And that kind of clouded my initial opinion of it. How about Paul, you have experience?
One of my partners uses mepo a lot, and I think she's had sort of some saves and some didn't really do anything. So I think she's seen both ends of the spectrum. And then at the U here, they had a study where they were combining these for people. They used one and then the other
not
sequentially
combining
and
the
concurrently.
anti-eosinophils, but with typically like omalizumab was added.
Right, and then so the people that have been really refractory, they're starting to add these together. And
I don't know. I brought that up in our practice, and basically my partners said to me, "You'll never get both of them approved. I mean, if one fails, there'd be logic moved to the other." To me, there's logic. They work by different mechanism of action. Definitely, patients can benefit from both mechanisms. How you guys at the U have gotten it paid for is the tricky part. To get too expensive biologics paid for is we haven't been successful. Or I haven't pushed it very hard, I must say.
The other thing is when they get it approved at the U and they try and transfer them out to us, it has to go through a whole new prior approval process. They won't take the U's. So we have one that Dan sent me. She works at my clinic. She's got her own approval, and she sent it out. The whole process had to start over. So I don't know how you guys do things here, but you get approval that we can't get, which is very interesting. So we're still struggling. Well, I think so, but we're still struggling trying to get her reapproved. And she was already approved, and we can't even get her started. So it's very unique.
I put this up. I don't have an answer. I don't think any of us have an answer. But just interesting that two different groups could theoretically analyze the same data and come up with different answers. And I don't know what the right answer
Bessie's? How did he hypothesize, or what was the discussion there?
I candidly didn't dig into these. I'm a quick fill-in for who was supposed to be presenting, so I didn't dig into these deep enough to really answer the question. I'm going to move on. I promised Jamie half of the session here because when I knew we were going to be short of speakers, I asked her to come up with more papers, and then I want to make sure we give her time due for the research she did. So, Paul, you want to get yours out of the way?
It doesn't matter. She can go first, and if there's time left over, I can do mine. Mine's just another one of these, we don't know what to do with these biologic agents. But he didn't even talk about.
Well, a lot of our talks are going to be going a bit towards biologics as we get more and more in our field.
I saw him. Drew showed me where they were. Thanks. Hereditary angioedema.
Alright, so I have 4 papers that I wanted to talk about today. The first 2 had to do with anaphylaxis. The second one was a new oral kallikrein inhibitor for hereditary angioedema. And then the last one had to do with asthma. So we'll see if I can get through all of them. So I have no disclosures. So the first 2 were from the September-October issue of Jackie in Practice. And they both had to do with epinephrine use and anaphylaxis. So just a little bit of background before I get into the 2 articles. So the most common trigger of anaphylaxis in children is food versus intensity medications and insect venom in adults. And risk factors for severe anaphylactic reactions include asthma, cardiovascular disease, and a delay in epi. And there's some evidence that epi may be underused during anaphylaxis episodes. So the first article was titled Increased Use of Adrenaline in the Management of Childhood Anaphylaxis Over the Last Decade. And this was from a group in Australia. The study goal was to determine whether anaphylaxis management in a pediatric emergency department improved after they introduced a training program to emergency department providers taking care of patients. So it was a retrospective chart review project. As I mentioned, in Australia, they compared 3 different years. So they included 2003 and 2004 for their initial year compared to 2012, looking at the number of charts coded with anaphylaxis. The reason they had to use 2 years in the beginning was because the numbers were too small to just use 2003, they said. So, and then in 2010, they introduced sort of a 4-pronged approach to improve their treatment of anaphylaxis in the ED. So they incorporated the Australian anaphylaxis guidelines into their ED protocol. They had an anaphylaxis action plan that was printed out and they said readily available to providers. And then they had training sessions that were mandatory in person, both they said in-person demonstrations and videos explaining to providers how to use EpiPens. And then they had also discharge packets available that I assume were pre-made with information about allergy referrals, information about anaphylaxis information sheets for patients. And then they also directly dispense EpiPens to patients before being discharged. So they had one actually in hand, and they didn't have to go a period of time between being discharged and having to fill a prescription. So in the first set of years, 2003, 2004, they had a total of 83,000 encounters, and of those 92 were coded as anaphylaxis. They went back and went through the charts and excluded some of the charts that maybe had the that were coded anaphylaxis that they felt were not true anaphylaxis. And then in 2012, there was almost 72,000 encounters and 159 episodes of anaphylaxis. So just looking at these numbers, you can see that there were clearly more patients presenting in 2012 with anaphylaxis than in 2003, 2004, especially since they had to combine 2 years to get the 92 in the first 2. And they have a number of figures that were a little bit complicated, well, not complicated, but kind of busy, so I kind of circled the important things that I wanted to point out in yellow. So this is just the demographic factors, the baseline characteristics of the patients in the 2 time groups. So they went through and determined what percentage of patients they felt like were correctly identified as anaphylaxis, and they said that about 70% in 2003, 2004 were correctly identified compared to almost 90% in 2012. And then there were some differences in the ethnicity of patients. So in 2003, 2004, there were more Caucasians, and there was an increase in Asians and African Americans in 2012 presenting with anaphylaxis. And there were some differences also in the triggers. So there were some more patients with food allergy being a trigger in 2012, 84% compared to 60%. And then there were more patients with insect venom triggers in 2003 compared to 2012. And then they looked at the symptoms that the patients were having and the vital signs that were obtained. So overall, the symptoms were fairly similar. There were more patients with wheezing in 2003, 2004, and more patients with shortness of breath in 2012, but wasn't entirely sure what to make of that because they're both respiratory symptoms. So, and then there were more patients with angioedema or urticaria in 2003, 2004. And then if you look at the bottom, the circle I have is the vital signs. And at first I thought that this was a difference in what the patient's vital signs actually were. But this is just if they were recorded, which I thought was a little bit bizarre. I don't know how you can walk into the emergency room and not have specific vital signs. And none of these were 100%, so I don't even understand that at all. So, for what it's worth, more vital signs were obtained in 2012 than 2003. And nowhere could I find anything about what the actual vital signs were. Were they more hypotensive in 1 year? More respiratory distress? They didn't, have any of that information. And then they looked at how patients were arriving to the emergency department. There was no difference between the years. Were they coming by ambulance or by private car? There were some differences in where they were discharged to. So in 2003, 2004, they were more likely to be discharged home, compared to in 2012, they were more likely to be discharged to an observation ward that was like 4 to 5 hours, as opposed to being admitted to their regular inpatient ward that I assume was overnight. And then they did have more patients that were prescribed an EpiPen and discharged in 2012. So 80% of patients in 2012 were prescribed an EpiPen and discharged, compared to 50% in 2003, 2004. And then more patients in 2012 either already had an allergist or were given information about an allergy referral at discharge. And then, again, this is sort of a busy slide, but I just wanted to point out two things here. So they looked back to look at the percentage of patients that were given epinephrine, and then they looked at the patients where the charts that they felt epinephrine would have been indicated based on the chart information, but it wasn't given. So in 2012, 28% of patients received epinephrine compared to only 12% in 2003, 2004. And almost 40% of patients in 2003, 2004 were not given epi when they felt like it was indicated based on the chart information, compared to 25% in 2012.
This is given in emergency or discharge with a prescription?
No, this is given in the emergency room. Yeah, as part of their treatment.
You didn't show it, so I'm sure they didn't draw tryptase as part of their protocol. And was there any intervention education-wise between these two?
So they didn't.
Between these decades, was there?
So they said that so they listed the 4 kind of things that they implemented in the emergency room, but they didn't say anything about outcomes in their results about, how much education the patients actually received. I assume that they, gave the discharge packets.
Oh, no, my question was, since they were looking at this, there was no public health intervention or education to the ER docs or the...
Yeah, there was. Yeah, here, I'll go back to sorry, it was kind of at the beginning. But, so they had these 4 things that they implemented. So they had anaphylaxis action plans that were more easily accessible, and the discharge packets and training sessions to the staff about how to administer EpiPens.
But the numbers still seem exceedingly low.
Yeah.
That's the point, is they educated people over a decade, and what are the percentages you're telling us?
The percentages in terms
who
of...
received epinephrine?
Yeah, so, where was it? Here. So, 28% received epinephrine in 2012 compared to 12% in 2003.
So these are people who are in emergency rooms with anaphylaxis, and those are the percentages that got epinephrine?
Yeah.
And did they publish this as a success?
Yes. So the other thing that was sort of interesting was that they published it. They said said that, oh, the improvement in the anaphylaxis treatment was based on all this training, but they compared 2003 to 2012, and there was a decade that went by, and they implemented this training session in 2012. There was no evidence that the training session was what increased the epinephrine use or, any of the other things that they meant. Yeah.
The data is still pathetic, no matter how you look at that. But did they have a reason why they didn't give epinephrine to these people? Why would you have a diagnosis of anaphylaxis and not give epinephrine?
Well, no, and the other thing, again, I was looking at was how severe, maybe some of the patients didn't have severe symptoms, a little bit of, hives but there was nothing in the results about how severe they're, in terms of the vital signs or anything else. So
the fact that they didn't take vitals, but epinephrine's cheap. It's the treatment of choice.
I think we should move on to the next paper. This one wasn't very successful.
It seems just in the U.S. that there's a bias in Europe not to use epinephrine, and is it the same in Australia? Or are they just their default is not to give it, and it takes a catastrophe to prescribe it?
Is there a reason for that?
We have a comment in the back row. Someone had their hand up. Yes, no?
There was data about interventions given before the patient arrived to the hospital by the ones that were coming by ambulance, if they got epinephrine.
No, they just said how patients arrived, but I don't recall them saying what they had received before arriving.
It was just the intervention by the ER.
Yeah.
Did they say what their formal definition for anaphylaxis was according to those guidelines?
They just said they went through the charts and looked to see if it was appropriately coded, but I don't recall any specific.
Published articles in Australia.
So, moving on to the next paper. So this one is by Ted Song. So this was also in JACI in Practice from the most recent issue. So this was titled Value of a Second Dose of Epinephrine During Anaphylaxis, a Patient Caregiver Survey. So the objectives of this study were to figure out administration issues and problems with epinephrine autoinjectors administration as perceived by patients or caregivers, to determine patient-caregiver adherence to EpiPen use, and the amount of education that they had received. So this was an online survey with descriptive questions targeting patients or caregivers, and caregivers were most likely to be parents of children who had been prescribed EpiPens. They recruited patients based on banners on websites, and then the patients were directed to a pre-screening questionnaire, and then a link was sent to their email, which once they clicked on that email link, then it took them to the actual survey. It was about a 45-minute survey, so a pretty intense, long survey. And the answers were based on recall, and it should be noted up front that the responses weren't validated against actual prescriptions, so this was just all patient or caregiver responses. So there was a total of 953 respondents, 500 were patients, and about 450 were caregivers. Again, caregivers were likely to be parents of children. 71% of respondents were women, and 75% of respondents said that they had previously administered epinephrine. The most frequently reported allergies were to food and insect stings. Most respondents said that they had received information about how and when to use EpiPens and when to carry them. Only 27% reported an emphasis on always carry 2 EpiPens. And this was the thing that I found most interesting, that 82% of respondents didn't carry 2 EpiPens at all times, and half of the respondents claimed that the reason they didn't carry 2 was to keep one in another location. So maybe they were prescribed a dual pack and they carried one on them, and they put another, at home or work or somewhere. 33% of caregivers said they didn't keep any EpiPens at their children's school, which I thought was also a pretty impressive number. 73% of respondents who said that they had called 911 or had gone to the emergency department in the past, 45% said they did so because of lack of access to a second EpiPen. And 50% of respondents reported that they had to use a second dose of Epi during a reaction in the past. And respondents who had previously administered Epi owned on average more devices than those who did not. So then they asked sort of what were the most common issues with EpiPen injections. So these were the most commonly reported things. So that they either pressed the EpiPen too hard against their skin, or they didn't press it hard enough against their skin. They didn't allow enough time for the injection to complete. The needle bent during the injection. They used the training device rather than the actual EpiPen. I don't know why patients were given training devices, but and then they injected into the wrong spot in their body, or they accidentally injected into the protective cover. And then the last one, which I found very concerning, I mean, it's only 0.2%, but accidentally used another injector, not the EpiPen. So I hope they weren't injecting like insulin or something else.
Like the first one, I didn't know you could press too hard and make it malfunction. Is that what the point is?
I guess so. I didn't know that either, but again, I don't know if this is just what patients were concerned about. Maybe it actually did function properly and they were just reporting that it didn't.
Does anybody know from like manufacturer, or anybody ever had that occur in their practice? Okay.
So then they asked, well, what contributed to the problems with the injections themselves? The most commonly reported thing was that they were too nervous, but then other responses were that they forgot the instructions on how to use them. They felt like they weren't properly trained on how to use it, or they didn't understand the instructions even after receiving training, or that it was too difficult to use. And I guess it's a little bit vague, but.
Do they break it down by device now that we theoretically have a device to overcome some of these?
I didn't see that in the results. I know that I looked at the survey and they did ask what were you prescribed, and so they had they must have had information about what device patients had reported being prescribed, but I didn't see that in the results.
Do you know who sponsored this study? Because that might tell you whose device we're talking about.
That I don't know, but I know that they had a couple different options. I think they had the Adrenal Click, the AviQ, maybe they had the EpiPen.
Well, they must have had the EpiPen.
And then they asked them, well, what did you do after you felt like you had a problem administering the EpiPen? What was, the next thing you did? And the most commonly reported thing was that they immediately tried to inject again using a second EpiPen. Some patients said that they immediately went to the emergency department. Some patients said that they waited and then tried again. I don't know how long they waited for. Some patients said that they called their healthcare provider and then tried the injection again. And then less commonly, but some patients were still reporting that they called 911. And then the last response could not locate my EpiPen. I'm not sure what they did after that. But so overall, I think the big takeaway that I took from this article was that there are likely improvements that can be made in discussing EpiPen use and the importance of always carrying two EpiPens.
You're falling into the trap here of calling them all EpiPen.
Oh yeah, that's true. Sorry. Epinephrine auto-injectors. It's a longer word to say. I think that, you have to take this study for, what it's worth. It's relying on recall. Obviously, they're not confirming that all of these patients actually are who they said they were, that they, were prescribed epinephrine auto-injectors. Certain patients may be more likely to respond to online surveys. It's a little hard to know if that's generalizable to the, everyone who's prescribed auto-injectors. And so the third article, moving on to sort of a different subject, was from the New England Journal of Medicine about a new oral kallikrein inhibitor for hereditary angioedema prophylaxis. And this was a phase 2 study. So I just wanted to kind of review the pathway and where this is working. This isn't the entire pathway. This is just the last couple steps. But kallikrein helps to convert high molecular weight kinagen to bradykinin. And the bradykinin is what mediates the vasodilation in the angioedema episodes. And and that's the step that's being affected with kallikrein inhibitors. So this was a phase 2 study, a 1-month-long randomized double-blind placebo-controlled study with a daily oral kallikrein inhibitor. Patients were only adults, so 18 to 70 with type 1 or type 2 hereditary angioedema. There were a total of 54 patients, and they were divided into 4 different groups based on dosing. So there was 62.5 milligram dose group, 125 milligram, 250 or 350 milligram dose group. I mentioned already that it was just a once daily dosing. So the patients had to have 2 attacks per month on average. They had to be fairly symptomatic. They were allowed to use a Catabant or C1 inhibitor for acute attacks during the study, and then they were given paper diaries to report the frequency of attacks, the severity of attacks, and where the attacks occurred during the study. The primary endpoint was the total number of confirmed angioedema attacks, and then the secondary endpoints included where the attacks occurred, so they broke it down peripheral versus abdominal, and then also quality of life scoring questionnaires. There were some differences in the initial groups, and I think just because the groups were so small that, one patient can make a big difference in the percentage. So there were more female patients in the 62.5 and the 125 milligram groups than the higher dose groups. And the 125 milligram group had patients who had fewer patients who had previously been on androgens compared to the other groups. The 350 milligram group had more patients who had previously used androgens and also had higher LFTs, specifically ALT coming into the study than other groups. And it was a little bit unclear whether that was related to their previous androgen use or some other reason. So the results were pretty impressive. So this is the mean number of attacks per week. So on average, they were having about 1 attack per week. And in the total number of attacks, the 125 milligram group decreased the frequency by about 73%. So dropped it to about a quarter, about 0.25 attacks per week. The 250 and 350 milligram group also had decrease in the number of attacks, but not quite as much as the 125 milligram group. And then if you look between peripheral and abdominal, only the 125 milligram group had a difference in both of those. The authors speculated that and I'm going to go through this, the side effects were predominantly GI symptoms, and so the 250 milligram group and the 350 milligram group had more GI side effects, and they may have been attributing those side effects to abdominal attacks, which may have accounted for why there wasn't a drop in abdominal attacks in the higher dose groups.
Stop taking it because they didn't like their side effects.
Yeah. And then the quality of life scoring, again, they broke it down by group. The placebo is the far left, the darker one going up. The lightest line is the 350 milligram group. And again, you can kind of just see looking at this that the 125 milligram group, that there were improvements in all the groups, with the 125 milligram group did the best out of, and it was pretty impressive, all the sort of quality of life scoring, they noted significant improvement compared to placebo. And then for safety, again, so GI symptoms were the most commonly reported side effect. Most were mild to moderate. There was one patient in the 350 milligram group who had to discontinue the trial due to severe GI symptoms. But in the 2 lower dose groups, there were only mild GI symptoms that were reported. 3 patients in both of the higher dose groups had mild or moderate liver abnormalities, and 2 patients in the 350 milligram group had severe LFT abnormalities. One had a GGT over 3 times the upper limit of normal, and one had GGT over 10 times the upper limit of normal, and an ALT above 3 times the upper limit of normal. All the LFT abnormalities did return back to baseline after stopping the drug.
Was that the group that had the more LFT elevations
Yes.
at baseline?
So they
44?
did have more, they had higher, the average was like 42, their ALT going into it. So I think, these patients might have been predisposed already going in, but clearly the side effects did seem to be also more severe in the higher dose groups. So I think overall the results are really promising. I mean, it clearly showed a decrease in the number of attacks. I think the results suggest that the 125 milligram group is probably the optimal dose, both for the decrease in the number of attacks and then also in terms of side effects. Obviously, a larger phase 3 trial is needed, but I think overall the results were pretty promising.
You can tell us the name of this drug.
So, yeah, they said it was, here I have it at the beginning, BCX7373. So no name. No name. That's why I didn't mention it.
The only thing that strikes me is it's a short study. 28 days is, you know, most of my patients, they obviously selected people with very frequent attacks. I mean, I follow quite a number of people, and most of them would not even have one attack in 28 days to be able to do such a short study. And not that I'm questioning that it wouldn't work over a longer time period. I'm just surprised they got it in the New England Journal of Medicine at such a short interval of observation. But
this would be such a radical improvement in our current therapy, though, an oral drug as opposed to $10,000 a month for an intravenous one. So.
Yeah, I mean, it's actually remarkable if you think about it, from a disease that we didn't really understand the mechanism at a point in our training to once you knew bradykinin was the cause and you could figure out how to block it, that you could come up potentially with curing this disease or controlling this disease with a pill, which was the reason to do research.
This dose response is quite peculiar. Did they talk about that, or other than the subgroups were a little different, or they studied, or
In terms of?
just the mechanism? I mean, you would think
Higher dose would
in the
work.
intermediate dose was most effective. So there's some rebound in the pathways with higher doses, or
That I don't know. I mean, I think they were attributing some of it at least to the side effects that were seen in the higher dose groups, but they did have some information about the drug levels that I didn't get into, just to confirm that the kallikrein was inhibited over the entire 24-hour period.
I was just wondering if it loses specificity at the higher concentration, you're knocking out other parts of the pathway.
Yeah, that I don't know.
Talking about price, it's interesting. I had segue here for a minute. A patient of mine who was reasonably well controlled on Nasal and then had a really rough spell and treated herself with a Catabant, and after 4 injections was not doing well, had a throat attack, went into an emergency room and was given C1 esterase. She showed me the bill for her emergency room visit, and one dose of C1 esterase was listed at $50,000. $50,000.
How did it work?
It worked, and she only had to pay $250, but society somehow still paying for these outrageous prices.
Going back to fresh frozen plasma here. A lot cheaper. That's amazing.
I don't know how much this medication would cost. I mean, I would assume if it's a pill, it would be cheaper, but I guess
You never know.
you don't know.
That's right.
So the last article I wanted to talk about had to do with asthma and the relationship between type 1 interferon and Th2 inflammation in asthma. And this has to do with some of the work, it's related to some of the work that I'm doing with Matt and the Inner City Asthma Consortium, because we're also looking at this relationship. So many asthma exacerbations are associated with viral infections, especially rhinovirus. Patients with allergic asthma have been shown to have more frequent and severe asthma exacerbations. And previous work, especially Matt's work, has shown an excessive type 1 interferon response in pediatric asthmatic patients correlates with reduced lung function, but the exact relationship between the antiviral responses and the Th2 inflammatory response hasn't been clearly sort of identified. So this was a in vitro study looking at the relationship between Th2 and type 1 interferon gene expression in asthmatics. So they looked at 2 different groups of patients. The first group was mild asthmatics that were not on inhaled steroids. 32 subjects compared to 22 healthy controls. They underwent spirometry, bronchoscopy, and blood collection at baseline, and then did RNA sequencing of airway epithelial brushings to look at the different gene expression profiles. Then they treated them with 8 weeks of inhaled steroids and then repeated after 4 or 8 weeks. And then they had a severe asthmatic group. This was actually part of a different omalizumab study, and they used gene expression profiles of their blood at baseline before the study, patients on high-dose ICS/LABA compared to controls, and that was a much larger group of patients, 400 groups. So in the stable mild asthma group, RNA sequencing yielded 1,300 differentially expressed genes with increased expression of type 2 markers and interferon-stimulated genes and ER stress-related genes, but they didn't find any association between the type 2 inflammation and the interferon-stimulated genes. They did find that the interferon-stimulated gene expression was associated with reduced FEV1. And then they also found that there was a positive association between the airway and blood interferon-stimulated genes and airway and blood eosinophil gene expression as well. So basically what was found in the airway was found in the blood, vice versa, that they correlated with each other. In the severe asthmatic group, in the blood gene expression, they found sort of a similar finding that the interferon-stimulated gene expression was unrelated to type 2 inflammation. So just to go through some of their graphs, if you look at A and C here, were the ones I was looking at most closely. So there in A, they were plotting the type 2 gene expression compared to interferon gene expression, both from the airway. So there are white circles and black circles, and you kind of have to ignore the black circles because those are just the healthy controls. But if you look at the white circles, so it looks like there might be a little bit of a positive association, but they actually said that was not, the p-value is not low enough. So there was no association between those two. And then in C, they plotted peripheral blood eosinophil count compared to the airway interferon gene expression, and again, they found that they were not associated with each other. And then they looked at like FeNO on the right-hand side, FeNO and IgE compared with the interferon gene expression, and those were also not associated. Here is their plot showing that the interferon gene expression on the x-axis did correlate with baseline FEV1 and bronchodilator reversibility. So A is, the top graph is FEV1, and B, the bottom graph is bronchodilator reversibility. And you can see in the, again, you kind of have to leave out the black dots. But in A, you can see that there's sort of a negative association, and then in B, there was a positive association between those two. And those were statistically significant. And then here they plotted basically the blood compared to the airway for both interferon gene expression and then type 2 inflammation. C is the interferon, and D is the type 2 inflammation. And again, I don't know why they changed the colors here, but the asthmatics are in red, and the black dots are the controls. And those were both positively associated with each other. So again, what's found in the blood is also sort of what's reflected in the airway. So overall, this was the only study that I could find looking at the relationship in vivo between interferon-stimulated gene expression and Th2 gene expression patterns in asthmatics. And this was at baseline, so not in the setting of a viral infection or an exacerbation. But they did find that airway interferon gene expression was associated with reduced lung function, but that there was no relationship between interferon gene expression and Th2 inflammation.
Can you show my ignorance, so what?
So this is what I'm looking at with Matt. So we're looking in the setting of viral infections and exacerbations. Is there a relation? So the question is, so there are seems to be some relationship between viral infections and Th2 inflammation and asthmatics, that both of those things together make exacerbations worse. But what is that interaction? And so there really isn't a whole lot of information. There's some in vitro data that implies that they may be inversely related to each other. So increased interferon might downregulate Th2 expression and vice versa. And so this is the only study looking at those two things in vivo.
What about your study group? How, does that differ? Do you have some preliminary data that's contradictory, or
yeah? So one of the things that we found was that there seems to be a so we were plotting airway interferon gene expression compared to airway Th2 gene expression, and there seems to be sort of a U shape. And so there tends to be an inverse relationship, but at some point that kind of breaks down. And in patients with higher interferon gene expression, there tends to be more of a positive relationship. And that positive relationship seems to be more in patients who have a rhinovirus infection as opposed to patients either who have different viral infections, not rhinovirus, or have URI symptoms but don't have a virus that's isolated. And so it's a little bit different than this paper because it's pediatric patients who are in the setting of an actual exacerbation, not just at baseline. But
did you study bring down the types of viruses with their RNA?
So this study. So they mentioned that there were, I think, mostly rhinoviruses that were isolated, but again, these were baseline, so presumably they weren't causing an actual exacerbation. They were just, baseline, they cultured some viruses, but they didn't find any association with the viruses in this study. They looked at that.
When you introduced this, you said you had basically two studies, mild asthma and then severe, but then with the results, you didn't really break that down.
They didn't. So in the results, they didn't talk about the severe asthmatics a lot, and they didn't have any, the same types of figures that they had with the mild group. I think that's just because they were only looking at blood and they weren't able to look at the airway information. I'm assuming they were too severe and they didn't want to, do airway, bronchoscopy on severe asthmatics.
I think that'd almost be the more important group to look at.
Yeah.
Yes, the one that they didn't really look at.
Do they have any data on interferon level just versus viral load? I mean, even if you didn't know what virus it was, because theoretically that's going to go up as the viral load increases.
Yeah, so that they don't have any information on.
Would you speculate that previous use of influenza vaccine would have any influence on the outcome of the study like this? That last paper proves to be true in Jackie. About the negative effect of influenza vaccine, the absence of influenza infection being associated with increased risk of Th2 responses.
Oh, I haven't. I haven't read that.
Okay, it's extrapolating, admittedly, because we don't know the use, but.
So, sorry, say that again? What did it?
Well, there was the last issue of Jackie. There was a paper that was looking at natural influenza infection, and found that that was actually protective against Th2 type responses.
Oh.
And so raised some interesting questions. It's one paper, admittedly, but well done. With interesting, provoking science behind it.
Yeah, that's interesting.
Yeah, because it seemed like a variable that would affect it. Of course, there's no way we can know. But that's why I was just wondering, with your improved knowledge of molecular biology here, if you think it'd be relevant.
I wonder where my cell phone was. All right, let's leave last 7 or 8 minutes here for Paul, who kindly did a paper for us, and again back to biologics.
Yeah, that's intriguing.
Okay, so for me, when asked me to do this, and I've been trying to find out what biologic is the best for nasal polyps ever since we had this conversation a couple of months ago, and nobody would actually answer that question for me. So I finally said, I'm going to figure it out for myself. So there's a study back called the Liberty Asthma Study, and I thought I got this coup on nasal polyps and biologics, and basically this is a study on asthma, and all the data on nasal polyps comes back from the study in 2016. So they just keep referring back to an old study when it comes to nasal polyps. And this was MD Edge News, which is an online printout from Chest, and this was a study that was excerpted from a guy named Castro in the New England Journal about this Liberty asthma study, and it basically looks at dupilumab as an alternative for treatment with people with chronic rhinosinusitis and nasal polyps. So this Liberty study was 382 asthma patients with chronic rhinosinusitis and nasal polyps and 1,520 patients without. So when they started them on dupilumab, it was 600 milligram loading dose and then 300 milligrams weekly versus placebo. And if you look at the asthma data, the asthma scores decreased by 42% in the chronic rhinosinusitis patients and 40% in the nasal polyps versus placebo. The sinus scores decreased 52% in the rhinosinusitis group and 47% in the nasal polyps. And these were visual analog scores. And then the decrease in the SNOT-22 score. I love that, SNOT-22. That's a great name. And it was down 15 points in both groups. So they all statistically were significant, but there's not enough to separate them. So if you look at this dupilumab data back on nasal polyps, it's actually the 2016 JAMA study, which showed that the effects of subcutaneous dupilumab on nasal polyp burdens with chronic sinusitis. It was published in 2016, and the nasal polyp data was totally separated from the asthma data, although both of them showed favorable responses to dupilumab. There wasn't any new nasal polyp data in this study except for the fact that they separated out the groups with nasal polyps and not nasal polyps. So the way this study was originally done, they randomized 89 people, and you had to have a nasal polyp score greater than 5, and they look up your nose with a scope and they count how many polyps are in each nostril, and then you get a score for each nostril. And if both of them weren't greater than 5, they washed you out of the study, and then there's other reasons why they're excluded. And you can see that list. They had a bad SNOT score, they had been on prohibited therapy, which is usually another biologic agent, or systemic steroids, they had hepatitis B or C, and other things. So they randomized 60 people to get either Nasonex nasally plus placebo, and the placebos were injectors just like the dupilumab injectors. And the other group received dupilumab plus the Nasonex nasal steroids. And then by the end of the study, in the placebo group, 7 had withdrawn. Most of them had adverse events, but the comments were that they weren't getting better, so they withdrew. And then in the treatment study, 2 had withdrawn by the end of the study. So then, if you look at the data itself, and this is endoscopic nasal polyp score, so this one on the left is looking at the study, and it was a 4-week run-in, and then there was 16 weeks of treatment and 16 weeks of washout, basically. And these are the nasal polyp scores, and this is, again, a visual score by the surgeons. When they scope you, they look and see what your nasal polyp score, it's 0 to 8, and they look up there their scope, and they count how many polyps and how much they are. And then placebo versus dupilumab shows a pretty significant difference between nasal polyp score, and the second graph is morning peak inspiratory nasal flow, and they hook you up to a meter and you sniff as hard as you can, and basically they measure that over time. And again, they both show efficacy for dupilumab versus placebo, which is suspicious. But again, there's, like Len said, we're never going to see a head-to-head of any of these drugs because the companies don't want to do that. They just want to show that their drug works better than nothing, which we sort of already know. The second one is nasal polyp burden, and again, the first graph is when you look at the endoscopic scores, again, and it just shows more of the same. It shows a difference in time that dupilumab clearly separates away from placebo. And then you have I can't even read this, it's so small, my glasses. So the second graph is basically they're just looking at the data in different ways. And the first one is FEV1, and then you have nasal polyp burden, and you have difference in size of the polyps, and essentially everything shows a benefit of dupilumab. And again, this is specifically based on polyps. It's not looking at asthma data at this point. It's not looking at anything else. It's just looking at polyp burden. And the asthma stuff was thrown in with FEV1 and then the nasal scores after that. this third one, and these things don't really project very well. This is, again, improvement in breathing, and this is some of the asthma data, essentially, and it just shows a benefit of this Dupilumab versus biologic or therapy versus non-biologic therapy, which is, again, placebo for the most part. And then the last one shows there's really no difference between the two, except at the initial point, Dupilumab's better than placebo, and then the rest of it didn't show any real significance at that point. So when you get down to the last thing, and again, this is it's a rehash of an old study, but all the literature points to the fact that this is probably the best biologic agent for the treatment of nasal polyps, but it also treats rhinosinusitis statistically better than the others, and it treats asthma as well as eczema. So when you look at these biologic agents, we have different data that says one's better than another for one thing, and then you have this drug that says it's better than the others for pretty much all of the above. So I was interested in polyps. The asthma data and the sinus data was just a throwback to see what happens. But this one, I'm now getting questions from my clinical people that are trying to get as much money out of this reimbursement as we can. Can we give these Dupilumab shots? Can the patients do it at home? So this is the only biologic that has a disclaimer that says it has no immunosuppression. So all the other ones we give, they're going to warn you about immunosuppression. This one says it does not immunosuppress you. So that's the only one there. And now the question is, with insurance, with us having to give this shot, we're not getting reimbursed. Now the question is, can we let the patients give it to themselves? So not only is it probably better for polyps than the rest of them, which is a burden for me. My nasal polyp burden is the same. My patient burden is the same with nasal polyps because these people are crazy and they're miserable. Can we let these people do this at home? And I just was going to throw that out to the group. Has anybody even thought of that option? And has anybody got any experience with it? So that was my question. But this, I think, for polyps, this is the best drug we have at this point in time. So is anybody letting anybody use it at home? Has anybody had any data with self-injection? Jonathan?
An N of one, myself.
Oh, you take Dupilumab yourself?
Yeah, and it's working very nicely.
So you've had good luck with it then?
Yeah.
And then
So when you make the statement, though, do we have comparable data with any of the other biologics and their efficacy on nasal polyps?
Well, they all say they work. The problem is that there's no head-to-head data, as you commented. They don't want there to be head-to-head data, so all you have is the statistical improvement of this drug versus the other drugs. So, I mean, this is a 50% decrease in burden, whether you measure FEV1, sinus score, SNOT 22, whatever efficacy pattern you use, it's at least 50% for pretty much all of them. And the issues with the side effects of the drug are just injection site pain is really the only thing people complain about. But we get sort of something for free. You get to treat their asthma, their sinus disease, and their nasal polyps all at the same time. So this is sort of an N of one where you use one drug to study against all the other ones. And it would be interesting to see Dupilumab versus all the other biologics. And I get the sense your comment, nobody's ever going to do that. So we're not going to see that data. So we're going to have to assemble it ourselves. And it'd be nice for the fellows if they want to get a great study at the U, and you can get magical improvement for these drugs that I can't get. So if you guys could get approval for Dupilumab to study against everything, that would be awesome. And Dr. Davis in ENT may be really interested because I think this is the drug he wants us to use, but he won't tell me by name which biologic agent he wants to put my polyp patients on. He just says, put them on a biologic, and then he won't answer my questions after.
I know some of my colleagues have referred patients to him, presumably to make the decision should they have surgery or not, and he's kind of deferring to, let's try a biologic before I operate on these people. So he'd like, I think, I haven't talked to him directly, a number of cases to disappear that he doesn't have to operate on out of the failure rate that we've had before with chronic rhinosinusitis and polyps and people who only get a transient improvement.
Well, again, this is a burden on all of us because these polyp people, they're extraordinarily difficult to manage and they're completely miserable. And if we can do anything to help them other than systemic steroids and surgery, I think we sort of owe that to them. Yeah. But boy, it would be really nice if we had somebody like in a position where you could actually do a head-to-head study. That would be really great to do that. But I don't think that there's any interest in industry to run this drug against their drug, unless there's a study out there that I couldn't find.
No, that won't happen because there's no financial incentive to do it. We'll just learn from experience. But I must say, this drug, we now have data that it's good for eczema, asthma, rhinosinusitis, so it's looking like a very promising agent for
It just shows
almost everything we deal with.
The IL-4 alpha receptor seems to be pretty important in a lot of these diseases, more important than all the other options. But anyway, I would encourage any comments, because I came away from this thinking I got the answer, but I'm not sure I have an unbiased answer. I have my answer. This is what I'm going to use for my polyp people, so I don't know if that's a good answer or not. So.
All right, well, thank you all. Next week we have a guest speaker. I think I'm out of town, but we have a guest speaker from Genentech.
Jerry's going to talk?
No.
How long you been down there? Oh, okay.
I work for ED also. And reflux. I think it treats all of it.
I saw one of your.
I don't know.
I
wish somebody would just say use this. And I can't get anybody. So I was telling Jerry, I use like Zolar 99 to 1 over all these other biologics because of all my chronic hives.
Yeah.
So I mean, and they're so easy to deal with. It's just like call them
right after.
And then all this other stuff. I mean, Dan has sent me a couple patients that have already been approved. That then they come to my clinic just to get infusions, and we can't get them reapproved.
They had him in isolation.
And they're Boeing. They require another approval, and they won't even let them do it. So it's just been crazy.
It was a management nightmare being incarcerated.
And I can't.
I know.
Things done,
I can't figure out what why if it's been approved once by the same insurance company, why they won't approve it. But that's kudos to your company because you just don't have to deal with that.
Unfortunately, had a high ITE.
It is.
Non-specifically.
Oh yeah, yeah. There was like
all sorts of not part of the thing there.
Yeah.
Maybe it's because they're here. I don't know.
You mentioned that.
They transferred it around the
But it's intriguing.
Oh, okay. I think they don't know I'm here.
He said Walla Walla.
And it's changing in a matter of months. It's not changing by years anymore. Now with all this electronic people, it's like a week.
3 guards with 3 guys.
Yeah.
I felt like I was with the safety.
Yeah.
And at one point we were talking like this, and we have more of our aggressive shooting.
And they've been on it for over 15 years.
3 linebackers there. Yeah. It wasn't that good. And when we had, it was like Loretta.
I got it.
What is your production? Luckily I had a medicine of 6-4. I just wish this is a light turnout. Tough guy. And we have a really steady audience coming back. I don't know. I often don't know how many people send out. But you had a more reasonable interaction with giving it. Maybe almost you're listening to them. Come every week that you can.
Probably won't make it every week. I've got a little toddler, so you gotta put out. Yeah, no, definitely.
Oh, sure. So sorry.
Okay.
Oh, so we're set up for,
You're not going to
but I'm going to be in the hallway there.
sneak around. Call the guards.
No, taking this.
That's not where you're looking.
I mean, I'm anywhere right today.
Right. I'm not far. I'm in Greenwood. Okay.
But I'll
Yeah, it's fine. Have you lived here now? It's nice here. It's terrible.
yeah.
Ireland? Yeah, but I was in Australia before, so. Okay. Oh, yeah. Yeah, a little bit. We're going to hang right here for a while now. I'm tired of moving. Yeah, sure. Do you ever get some reason? Either we have visitors or they show us. Okay. Are you nearby?
I live in Upper Cleveland.
Oh, right there.
They're very big on their product.
But usually,
This drug comes out.
basically my name's Brooklyn, and now I'm coming to the dentist most of it. And I come
Yeah, I haven't read this.
Yeah, but that was
Because it's they only find X number of studies.
Right.
So they should do the same studies. It should come comparable.
depending on.
Were they, were they comparing the same stuff?
They,
Or did one miss it?
No, so someone else was bad. So they kind of like
And why did they miss it?
and then they. So I was wondering if that was right. No.
I mean, it's like,
Yeah.
we don't usually. That was something.
I'll do it
chose
over
to
tomorrow, but. It's kind of like.
Yeah, and wasn't there differences in the studies?
There was a lot of.
And one group had much more sicker group.
So maybe.
I mean, the comparable reduction was the same, but
Well, yeah.
did they correlate, did they kind of compensate for that?
Because we only have one.
Oh, okay, so that'll be coming out.
I think they're going to
Well, I'm there Saturday, Sunday, Monday, Tuesday.
Yeah, I would actually. Okay.
There was an earlier study that there was
You can find one, and
there was a French study.
yeah, and there's
A couple years
one
ago.
from Infectious that just came out that includes Dupilumab. There's a ton of it. So we were like trying to figure out if there's any utility and put something together to
See
see
her,
like, this one next year, this one next year.
Yeah, some I think they really
Yeah, it like literally just kind of breaking down where they chose to match, and like, for example, some of them are items.
Dr. Altman?
Yeah, these kind of comparisons after the fact, I think,
Yeah.
it's just going to turn out data like that.
Right.
I'm going out to Redmond, Northwest Arizona.
Okay. Okay.
Right now, yeah, we've got to get
I used to be an MSL today.
severity index for our patients. We've got a lot of
Now, and
can't
the
stay
sales
here.
people sent me
I don't know whether they'll take it.
a question about
but, you've got
and I don't
500
even
people.
know. But I just want to.
You know, we can get that. We
So Dupilumab, I can't we have not necessarily.
I don't know.
So in case you have any questions.
And that's what, a lot of them are trying to, with this,
Yeah.
Oh,
Do you have finish it?
yeah, it's like the university also got asked if anyone has, I would like to switch to one from another. I would recommend it.
I don't know. Yeah, I mean, I know a lot of people have. Even you. No, that's interesting. And same thing with Polyps.
Yeah, I saw that you're coming
They've got
used
a
to be
study.
Yeah, you got a study.
Yeah, that's where I met you.
GSK's working on a study. It's done, Leslie just done like a history analysis of the patients, but no, it's not. That's why that's what you're gonna get next is the ITCs and then.
Yeah.
And you know Dupixent was approved for asthma.
Yeah, I think that'd be very helpful if you could come up with key points of how the studies are different and just to learn people. You know, because I mean, Len don't maybe didn't. I just couldn't
I
believe
was covering
it.
11 states. I don't remember what your question was.
Yeah, I can't even remember.
It got answered.
Yeah.
No, there's no.
So
And they
study
kept
effect.
publishing their in-house
You're
paper
talking about
that they published. So
Yeah.
why aren't the? I mean, that's why I was thinking of program or something where at least you get a group of people that are.
Yeah.
That's
Yeah, well,
Factory
Program's
it.
got one already
I
too,
think I have enough.
of this.
of the biologics.
When did that come out? Oh, that was the initial one, but
I don't know if they had to.
I'm not sure. It's
Yeah.
been
the data. I mean,
Yeah.
keeps coming
I
out.
think the
right
issue
now
with
is
the
not
Cochrane one is it might have
you know,
everything that's
they may have had a position
That's what I mean.
Yeah.
It needs a new one.
No, but yeah, no, it's different because these guys show some match on ESL mode and try to.
So you want to come back to Seattle? I can keep my ears
study,
open.
like the Pimple McBride study, so I have two Dutch patients getting like
Yeah, I used to work in
now we're looking at a lot of
a general hospital. I commuted from Seattle, and my boss kept trying to get me to move down there, and I just couldn't do it. I don't know.
The other one, I don't know about the
and some of
other
them
two
now.
that I do know about.
It is.
Nice restaurants and stuff. It's really nice.
I don't know.
I will say it's really changed.
But the Ipcar one that just came
Yeah,
out.
yeah, that's a restaurant.
And if I had to keep driving out there.
Oh, okay.
Yeah, we definitely need to revisit that. We're getting probably going to separate provider thing.
Oh, yeah, yeah, I've known him since I was
That's a
in
good
it
area to
depends.
jump in.
You gotta really look at the
Yeah.
I mean, it's
No, I know him.
it's a practice style.
Yeah, yeah.
Just doesn't work for me. It's
Yeah.
a business that's non-violent.
Yeah.
ways to choose to try to.
Yeah, exactly. When you start throwing that group.
So I have to get out.
And that's what they're doing. But yeah, no, I'll keep you posted. And we
Okay,
just
yeah,
started working on that.
anything you got, especially if
If I
the
have
other stuff comes out.
Yeah.
Just in your about the time.
Yeah, hopefully we are. I
Or
think
an abstract form if you present it.
Yeah, we presented an abstract in terms of
Yeah.
I mean, it seems like you're telling them.
Yeah. Long enough now that.
Yeah.
No, most of the line. Yeah, I've been trying to get the word out. So.
Yeah. And I'll tell the other MSLs, that was a Teva MSL. I don't know if you know her, Amanda. Tell her that. Keep her ears open for you too.
Yeah, sure. No, really appreciate it.
Okay. Good luck. Yeah.
Yeah, thank you.
That's a.
Yeah, no, I'm just keep looking until something happens.
Something will come up.
Yeah,
It always does.
exactly. So, yeah, that's the way I look at it. Is for the long term.
Yeah.
But it just would be nice if that
Yeah.
was sooner rather than later.
Yeah.
So, yeah.
Well, good luck. It was nice to meet you again.
Yeah, likewise.
I'll keep my ears open.
Okay, thank you very much.
I think I have. It's.
Do you need my email or something?
Do you have like an email that you give out to?
Yeah.
I mean, I won't send anything to you.
Yeah. I use my university account.
Oh.
Still.
So it's
So
J.
it's just J Becker.
You dot.
Yeah, you dot.
Washington.edu. Okay.
Yeah.
All right.
J Becker.
Okay.
Yeah.
Thanks a lot.
Okay. All right.
Bye.
Okay. Hi.
There's no rush.
Getting caught up with everyone. It's been a few years since I've been here.
Oh, that's awesome.
Are you with Allergy, or you're with the next group coming in?
next group, I guess. I'm in Immunology department.
Oh, okay. Are you faculty, staff?
Postdoc.
Postdoc. Oh,
Yeah.
okay. Yeah. Well, just say hi anyway. I'm in Allergy. But yeah.
My name is Michelle Messmer.
Hi, Jonathan Becker.
Nice to meet you.
Yeah, nice to meet you too. Is Hans Ox down this way, or? Is
I do not know.
Okay. Yeah, he's an immunologist that that I know from Children's.
Oh,
he's been
okay.
practicing. Well, I mean, he's like in his 80s now.
Oh,
and
wow.
He's still practicing.
Yeah, that's awesome.
Yeah, my whole career as a med student. I mean, even before med school, when as a kid growing up, he was in the same neighborhood. But he's like a world-class clinical immunologist. And
that's pretty awesome.
yeah, if you don't know him, you may want to just look at least some of his publications
For
and
sure.
overlap in your interests. He's a wonderful guy, really wonderful, highly approachable.
And he's still here in the area?
Yeah. Oh, yeah.
That's
Still
awesome.
practicing. Yeah, still practicing. Has his lab. He's going to die in office, literally. Yeah.
That's impressive, though.
OCHS, Ox.
Okay.
OCHS.
Yeah.
It's the spelling, Hans. Yeah. Yeah, he's a great guy. Well, good.
Very cool.
Yeah. Well, I wish I could stay for this, but I'm going to have to get to work. So nice to meet you.
Nice meeting you too.
Yes. Okay, cool. Sandy called and was concerned that the bagels were...
Well, I said 8:15 to 8:30. I got here at 8:05. The guy was already downstairs.
Cool.
Yeah.
When's the meet?
Not till
9:30, right? Yeah.
Other people had said that they don't always come on time, so I wanted to make sure.
Just the coffee will be nice and cold.
No one will get scalded. It's for their safety.
Cool. All right.